have to be on time here. But this is a very important subject, so, and it's here close to my heart. So if you may remember, in 1928, Alexander Fleming discovered penicillin by chance, but it became only available at large at the end of the Second World War, thanks to these two men here. So systemic antibiotic has been used for almost 80 years, and it has unquestionable saved many lives. But unfortunately, the casual and non-judicious use of antibiotics has led to this epidemic of antibiotic resistance that we are facing now. So this picture here shows Alexander Fleming receiving the Nobel Prize. So the Nobel Prize in 1945, in his speech, he predicted if we human beings didn't use antibiotics, in the case he specifically said penicillin, judiciously, bacteria would develop resistance. So back then, he predicted that what we are living now would happen. So this is just some data from the United States, published by the CDC, that the Center for Disease Control and Prevention was in 2019, just to give you an idea of what's happening in the United States. And actually things are better than before, okay, because of some strict measures that have been implemented. So 2.8 million, almost 3 million people every year in the United States develop resistant bacterial infection. And 35,000 people die of resistant infection. It may not seem a lot, but it is a lot. So it should not be happening. So the World Health Organization predicted that if we don't change how we use antibiotic, by 2050, we'll be seeing more death from resistant bacterial infection than cancer, okay? So, and again, you could say, we may, I don't want to paint a very dark picture here, but we may reach the area of pre-antibiotics. So this is a very serious situation, okay? So the most important risk factor for resistance is bacterial resistant to antibiotics is what we call antibiotic selection pressure. Briefly, I'll show how this happens. So you see this figure here, these grayish, bluish bacteria are susceptible bacteria. The reddish ones are resistant bacteria. So antibiotic is given, these bacteria are exposed to antibiotic. All the susceptible ones die and the resistant stay, right? Now they don't have to be concerned about competing for food or space, and they grow, okay? That's what we're seeing here. There is only one susceptible bacteria now. And one thing to keep in mind, these resistant bacteria transmit the resistant gene horizontally through what we call plasmid, that's a fraction of the DNA of the bacteria that carries resistant gene. So they can do that very easily. So resistant infection can spread easily amongst bacteria, okay? This here, I don't have much time, but it's just to tell you that, again, let's say people was exposed to bacteria, animals, they develop bacteria, part of the microbiome develop resistance. They can transfer that resistance through other people, through other animals, to poor hygiene, contamination of surface, And so that's transmissible, okay? Bacterial resistance is transmissible amongst us and us to animals, animals to us. And here, again, you see mainly production animals. Resistant bacteria are present in the feces. You know, the gastrointestinal tract has trillions of bacteria. So they contaminate the environment, the soil, the water, and that goes back to people and other animals. Okay, this paper was taken from, this figure was taken from a paper published in 2022, so it's very interesting. The author interviewed small animal and equine practices just to learn how they've been using antibiotic. And they did that 3 times a year for 1 year. And they wanted to know, so what the diseases you use, here we're talking about systemic antibiotic, skin and ear, number 1, okay? And so, and again, the clinics were small animals, so dogs, cats, and they also interviewed veterinarians who work in the equine practice. So this was true when you divide by the specialty. It kept true skin and ear, number 1 for dogs. For cats, number 1 was respiratory disease and urinary tract disease, and then third one, skin and ear, okay? And for horses, number 1 was ophthalmic infections, okay? And then skin was second, and they didn't use any antibiotics in the ears of horses. So, yes, we prescribe a lot of antibiotic. Oops. What can we do to improve how we use antibiotics? So, implement in practice what we call antimicrobial stewardship. Okay, so, and there are a lot of things involved on that, but there is one thing that we are under control, okay, so we can do. It's again, if we have to improve how we use antibiotics. So if we improve that, hopefully it will have a significant effect in reducing resistance, okay? Okay, I don't know why. So today I will focus in how to treat superficial bacterial infection in this situation of resistant bacteria to antibiotics, because it's what you're going to be seeing more often. This is the most common bacterial skin disease that you'll be dealing with in practice. Some of the things I'll be talking about here can be extrapolated for other infections also, okay? So I will review with you 7 steps for you to consider when you diagnose a bacterial skin infection, okay? Or you are suspicious, I should say, of a bacterial skin infection. The first one, we have to recognize the various clinical signs of a superficial bacterial infection. Okay, the superficial pyoderma is one example that one disease can manifest in many different ways. So the skin challenges us. And there are situations also that different diseases will present similarly. But here it's the same disease presenting in many different phases, many different ways. And I think you are familiar with these lesions. All of these cases here are due to superficial bacterial skin infection. So once you are very suspicious that this patient, your patient, has a superficial pyoderma, you have to prove that bacteria is truly causing those lesions, okay? Why? Not always papular, pustular, lesions with collarette or crusts are caused by superficial pyoderma, by bacterial skin infection, okay? So here, for example, I looked at this dog. You see multiple collarettes, you see papules, some pustules. I said, this is a superficial pyoderma, no question about it. Guess what? This dog has pemphigus foliaceous, okay? So it's important that you prove that those lesions, typical of a pyoderma, are truly because by a bacterial infection, okay? So what is the first thing you do in that case? So you saw that dog with all those lesions, say, I have a superficial pyoderma, what do? Cytology, thank you. So definitely cytology, okay? So what do we expect to see? Cocci bacteria, extracellular, ideally intracellular. Don't rule that out if they are all extracellular. Just in that point in time, it happened that you didn't see a neutrophil phagocytizing it, okay? And why cocci? Why do you think that this is the expected finding? Because what causes superficial pyoderma in most cases? Staphylococcus, most of the time, pseudo-intermediates. Very rarely Staphylococcus schleiferi, more often in the ear than skin, and very rarely Staphylococcus aureus in dogs or cats, more large animals, in people for sure. Okay, that's what we would expect. So now, step 3, consider performing bacterial culture in susceptibility. Let's talk about it. Never wrong, okay? Nowadays, with this era of resistant bacterial infections, it's an epidemic. Most of the cases we deal with, it's not only methicillin resistant, but multi-drug resistant. So it's serious because then you cannot treat properly your patient. And so we are culturing. Every time we're facing with rare exceptions, a case of superficial bacterial infection, we culture. Never wrong to do it, okay? Nowadays, you should do more and more cultures. Hopefully, get a good laboratory, because that's important too. In this study, quickly, so what they did is they collected samples from dogs, first time pyoderma, never exposed to antibiotics, and did culture and susceptibility, and they had samples sent to their laboratory, and they look at the bacteria, the susceptibility of the bacterial strains, Staphylococcus from first-time pyoderma, Staphylococcus from dogs that most likely received antibiotics previously many times, and even the strains that had not been exposed to antibiotics before developed resistant, okay? So the resistant were not just penicillin, because you expect Staphylococcus pseudo-intermediate or any Staphylococcus to be in general resistant to penicillins. They were resistant to clindamycin, resistant to potentiated sulfas, to cephalosporin. Less frequently than the bacterial strains isolated from dogs that were exposed to antibiotics before. But were also seen in the patients that never received antibiotic before. Is that transfer, horizontal transfer of resistance amongst the bacteria. So, however, ideally, yes, culture every case of pyoderma that you are seeing nowadays. But we know not always is possible, and money is often a concern. But I'll tell you, you should, if you think that patient should have culture susceptibility, you should convince the owner to do that, to spend the money and do a culture susceptibility. Use strong arguments there. Talk about the resistant infections that we are dealing with, that if you just treat it empirically without performing culture and susceptibility, it's possible that the antibiotic it's not going to work. You spend more money with that. Then you have to change the antibiotic. There's another visit. So convince the client. Select your arguments there, but convince the client. So then we have some guidelines for you that we practice those guidelines also. When to perform culture susceptibility. History of many courses of antibiotic. Most likely, Staphylococcus has developed resistance to antibiotics. So don't just select one blindly, okay? Lack of response to empirical antibiotic. Let's say first time bacterial infection, never been exposed to antibiotics. I said, perfect, I'm just going to select the first tier, we'll talk about the tiers, antibiotics, cefalexin, for example, amoxicillin clavulanic acid, okay? And then you recheck, you always recheck, another important thing, you recheck minimum maybe improvement, and then you said, ooh, this is a new lesion, ooh, this is don't just pick another antibiotic, so blindly again. Perform culture and susceptibility. History of methicillin resistant, staphylococcus subintermediate, or multi-drug resistant. Often, if staphylococcus is methicillin resistant, we'll talk a little bit about that, that staphylococcus will be multi-drug resistant. I may be speaking too fast because he's going to kill me if I'm not done on time. When intracellular rods are present on cytology, you should be thinking here, which is rare. Usually, this bacteria that I'll mention in a second here doesn't cause pyoderma very often at all. Years more. It's our Pseudomonas, okay? So culture, that's not an option, okay? Deep pyoderma. I think Dr. Marcella alluded to that. It's important that you perform culture and susceptibility. Those infections take a long time to resolve, and you want to make sure that you are using, day one, a proper antibiotic here, okay? Let's go. Okay, step 4, select the proper antibiotic. Let's talk about that. Which antibiotic should I use? Consider the following. Antibiotic spectrum of action. I'll talk about this a little more. Antibiotic will penetrate the affected tissue. Side effects of the antibiotic. That's an important element that you have to take into consideration also when choosing an antibiotic. In the patient, general health, any kidney, any liver disease where antibiotics are typically metabolized, patient is taking other medications that can interact with the antibiotic you're giving. On our ability to administer the treatment. We'll put a parenthesis, we'll talk more about this. Don't feel like I have to be giving antibiotics that is given once a day. Because again, compliance, don't presume that. If you educate the client to give them that antibiotic, how you are prescribing, they will do that. I practice in an era that we didn't have antibiotics that you give once a day to treat. Before, fluoroquinolones, before cefpodoxime, that you give only once a day. And I had clients compliant. So educate them, okay? Don't just use once a day because they are second or third tier antibiotics, which should not be your first choice, okay? What else here? Vulnerability, cost to the client. Obviously, that's an important factor also. So, tiers. I want you to copy in color this feature. You have it there. I can send it to you if you want. Frame it and put it in your clinic, in your exam room, because it will help you say, okay, what are the first tier antibiotics? Those are the ones I'll go first. And then you think maybe second tier ones. So it should be in your notes, this, but I am serious about that. Put that because you won't remember exactly where the antibiotic is, second, first, or third tier. We modified this table here, so most publications put fluoroquinolones in second tier, but fluoroquinolones we want you to choose as your last option, okay? And you look, pay attention there. Tier 2 and tier 3, I say culture. If for a reason you decided to pick an antibiotic from tier 2 or 3, only based on culture and susceptibility. These are the ones you should be choosing, okay? So first generation cephalosporins, okay? It's cefalexin, cefadroxil, amoxicillin, clavulanic acid, a lot of people use it. Potentiated sulfas, remember of the hypothyroidism. And again, potentiated sulfas have more potential side effects. That's why I don't, it works beautifully, but that's why I don't use it as often. See that first year I put clindamycin for sure culture, because not everybody does what I like to do, because what can happen with clindamycin is if a strain of bacteria is susceptible to clindamycin, you only know based on culture, but resistant to erythromycin, which has a different class. Clindamycin is a lincosamide. Erythromycin is a macrolide antibiotic. So it's possible that during treatment, it's kind of a marker, the bacteria will develop resistance to clindamycin. Then it's a wonderful antibiotic for skin, but I just say, okay, is a bacteria susceptible to clindamycin and erythromycin? And then I can choose that as one of my antibiotics, okay? Oops, oh, just one thing here. See, this is in red. I put it in red on purpose. Avoid. Those are antibiotics used in multi-drug resistant, methicillin-resistant Staphylococcus aureus infections in people. So we have to preserve these antibiotics to ourselves, because guess what? If we don't use them carefully, bacteria will, which they're already more resistant to these antibiotics that we would want to see. So when to consider first-tier antibiotics? Whenever it is possible. Think of those first. First-tier, first, okay? And you have the guidelines for when to culture. And when we culture, you go, what are the first tiers? Which one I will choose? And then you can see side effects, you can see cost, you can see all those things. So what about second and third tier? Try not to use them, but let's say if the bacteria strain is resistant to all first tier, rare, then you can go with the second tier. But remember, selected based on culture and susceptibility. Second and third, culture and susceptibility, okay? Avoid. Pass quickly that slide. So, are the culture and susceptibility results reliable? Important points here, okay? The lesion sample, and Dr. Marcella kind of alluded to that, which I have a case that was interesting. I said, I'll present that case with acroleak dermatitis. So this is a deep chronic lesion. So if the sample is collected superficially, it's not reflecting what's deep in that lesion, okay? So lesion sample, in order of preference to sample, of course, a pustule. That's number one. If no pustules, they ruptured very easily because they're very superficial under a crust. Second, collarettes. Go at the edge, rub your swab there. Choose the collarettes that has some inflammation. And the last one, papules. And sometimes we see these pyodermas that's predominantly papules because they are hard to sample. But I don't have time to talk about it. But if you want to say, I can, talk to me, okay, later on. So the bacteria isolated. We expect it to be Staphylococcus, pseudo-intermediates or intermediates group. Sometimes that's what they report. What do we got? It's Streptococcus, or you say, that doesn't fit, okay? Amount of bacteria isolated, they should tell you the amount, and of course the susceptibility, right? So, okay, let's see here. All the important points, always compare the culture results with your cytology. Do cytology, okay? Then you see cocci, culture. Staphylococcus pseudomonas, beautiful, okay? Cocci, E. coli, ooh. And so I probably, could be us, didn't sample properly the lesion because E. coli is everywhere, so it wouldn't be causing a skin infection, no. So it could be the swab in where you place it to send to the lab, if it wasn't a media there to preserve the bacteria until it gets. So it could be multiple things. And sometimes depending, I think it's a lab error, I'll call them. So do cytology, okay, and then culture. Not all isolates are relevant. Don't feel like a bacteria was isolated, I have to give antibiotic because there is an infection there. No, be critical, okay? Some examples. Ooh, see if I'm okay, I think. Okay, so first, lesion sample. Why this? See, lesion sample. See, we love pustules. Dermatologists love pustules. And then we saw a beautiful pustule, and we put down beautiful pustules. So excellent. That's we want to collect samples from a pustule if they are there. Unfortunately, they rupture easily. Not always they are there, but they were there. And then results: moderate Staphylococcus intermediate group. This laboratory wouldn't go until specifying the pseudo-intermediate, but the intermediate group, the pseudo-intermediate is there as part of the group, so it's pseudo-intermediate. So look at this beautiful, which we don't see this nowadays anymore. So susceptible to basically everything, only resistant to ampicillin and penicillin. I expect that. Those are penicillins, and Staphylococcus are resistant to it, even if not, most of the time, because of the beta-lactamase that they produce. Even if not, you did a culture, you see, oh, penicillin, amoxicillin there, ampicillin, and they're cheaper antibiotics. Don't do it, because you're going to be very frustrated, and the owner's more frustrated than you, because it won't work. Even if it's susceptible in vitro, those penicillins don't do a good job with treating pyoderma, okay? Keep that in mind. This is beautiful. We, again, don't see, oh my God. Am I doing that? It's not my fault. Ooh, did I press? Okay. Yeah, just reason to celebrate. And we do, okay? Oh, I was going to ask you here, but okay. I went on the first tier ones, and we chose cephalexin. We could choose amoxicillin clavulanic acid. Let's see here. The bacteria is susceptible to clindamycin, and erythromycin could be clindamycin. I would just not choose potentiated sulfas because of the, again, more potential side effects, okay? But cephalexin, amoxicillin clavulanic acid for us at the hospital is quite expensive. And that's why we go more often with cephalexin to treat superficial pyoderma. Now look at this, how sad. Okay, so this bacteria strain, let's look at this first, okay. Numerous Staphylococcus intermediate group, lesion, pustules. I need more time to speak because this is delaying me. See? Okay. Pustule, great. And this dog was on antibiotics, so received multiple antibiotics. So not a surprise here. Look at resistant, susceptible to very few. Now, we say methicillin resistant often, right? What does it mean? In an antibiogram, look at oxycillin. You won't find methicillin because they use oxycillin as a surrogate for methicillin. So then look there, oxycillin resistant. When it's resistant to oxycillin, the bacteria strain is resistant to all beta-lactam antibiotics. So penicillins, cephalosporins, and carbapenems. The laboratory that we use, resistant to oxycillin, they go poof, 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 resistant to all the beta-lactams, okay? Because even if it's positive, there's something wrong with the culture, okay? So then that's what they do in human medicine, the same thing. So now, is this a multi-drug resistant infection? So is methicillin resistant? Is it multi-drug? It has to be, the bacteria strain has to be resistant to at least 3 classes of antibiotic. Then let's see here. oops, I already did it, because this is just to show all the blue ones are the beta-lactam antibiotics, so definitely methicillin resistant, and the different colors are different classes, okay? So here, clindamycin, which is a lincomycin resistant. Then we have here enrofloxacin, I think we had marble too, so fluoroquinolones resistant. What else do we have? Erythromycin resistant, which is a macrolide class. What else? And even trimethoprim sulfa resistant. So this bacterial strain, and I'll tell you, this is what we see more often nowadays than the previous case, okay? It's not only methicillin resistant, but multi-drug resistant. This is very sad. So what's left for us? Amikacin, aminoglycoside. We don't use aminoglycoside. It's injectable, lots of side effects. We don't use to treat superficial pyoderma, okay? Only if the dog is seriously ill or nothing else is possible there to treat. So this doxycycline, okay, gentamicin, again, another aminoglycoside, we won't choose that. Penicillin, so susceptible, rifampin. Rifampin is a very good antibiotic to treat Staphylococcus pseudointermediate, but this side effect, hepatotoxicity, can be bad. We lost a dog from hepatotoxicity on rifampin. So a lot of colleagues use it. We only, again, nothing else is there for us to use, okay? So then what, I wish I could ask what, but I don't have time for that. So then tell you what we chose here. Reason to cry. It's sad. We chose doxycycline and mupirocin. Mupirocin is an ointment excellent for Staphylococcus infections. It penetrates the skin well, has a very good effect. However, I recommend you using mupirocin only for cases like that, multi-drug resistant cases. Why? Because they use mupirocin a lot in people to treat methicillin resistant or multi-drug resistant Staphylococcus aureus infections, and even to, in the nose, to decolonize the nose cavities, okay? We use it sometimes, but we're only in situations like that, okay? Okay. You could even consider using chloramphenicol. First, I don't like chloramphenicol, not even doxycycline. Doxycycline is okay, it takes longer for the infections to resolve, but chloramphenicol takes longer also. It's 3 times a day, ideally. It has more side effects. So all those things you have to take into consideration to choose your antibiotic. But the spectrum of action, number one, you're going to apply, okay? It's that little table, first tier, first, okay? Okay, now another case. See, it was the sample from the surface of an acroleak dermatitis case. See what we got? Light growth of beta-hemolytic streptococcus, light growth of Pseudomonas. Pseudomonas is everywhere. Pseudomonas is an ubiquitous bacteria. Soil, water, plants, it's everywhere, okay? So this is, okay, look at the susceptibility there. Strep was more susceptible. Pseudomonas, not a surprise, resistant to various antibiotics. But I looked at this here. Based on that, the way they collected this sample, not ideal for this type of lesion. So don't treat, okay? And now what you have to do? Collect again that sample. The infection in acroleak dermatitis is deep. Get that plaque, nodule kind, pinch it, and see if exudate will come from the deep skin. If it does, clean the surface first, pinch it, and then you collect your sample, okay? Or if not, and if you, the antibiotic, as Dr. Marcella mentioned, it's important to treat acroleak dermatitis. biopsy, a 2-millimeter punch biopsy, and do culture tissue. Okay, take out the epidermis and put that little tissue in your swab. Tell the laboratory, I'm sending a culture tissue, because otherwise they get that swab out, the tissue goes to the floor, and they know how to process that sample, okay? What about empirical antibiotic, meaning selecting the antibiotic without performing culture and susceptibility? I cannot believe the clock. I have to finish. So, okay, empirical, it's okay, but in which conditions? In this situation I use empirical antibiotic to treat infection for many years, but many years ago, okay? Nowadays, it's a different story. First-time infection, okay? Yes, you can try empirical, but look at your table. First year first. No history of methicillin-resistant or multi-drug-resistant infection, not a deep pyoderma. The rule is deep pyoderma, I'm culturing, okay? So when waiting for culture results, I don't do this. It mainly for, again, severe cases. Superficial pyodermas, you don't have a very severe case, but as I mentioned, some of the things I discussing here apply to other types of infection. So I'll show you a picture when I would say, no, I have to start empirically an antibiotic now until I get the culture result. So don't prescribe in this case for more than 10 days, because you may change, and I hope you will change, we call de-escalate. I'll show you in a minute here. So we talk, again, do not use empirically, very important. When we had the workshop, one of the dogs were on ampicillin or amoxicillin, I think, to treat the superficial, pure amoxicillin without the clavulanic acid. Oh my God, the bacteria will be happy, poof. And so kill the antibiotic there. Okay, so it's okay. The penicillins is because of beta-lactamase. Again, bacteria will be resistant to them. And tetracycline is just because it doesn't work well. Those are the cases that I'll say, okay, I will start empirically an antibiotic based on the history, see which antibiotics this animal has been on previously, and try to not select those antibiotics, okay? And then when it comes back, that's the escalation. Okay, I was using a second-tier antibiotic. Now, the bacteria strain is susceptible to the first tier. If it is, I'm changing. Okay, so this is what you should practice nowadays. So always try to de-escalate. A few things to consider. Again, in cases of methicillin resistant, don't use the beta-lactam antibiotics. What are they? Penicillins, cephalosporins. In carbapenems, we typically don't use, but mainly penicillins and cephalosporins, okay? And the penicillin I'm talking about here is not the ampicillin, but it's the amoxicillin clavulanic acid, okay? Because the clavulanic acid will inhibit the beta-lactamase. Increased risk for selection of high-level mutant methicillin-resistant Staphylococcus aureus, fluoroquinolones. And that's why we took fluoroquinolones from tier 2 and put it as a separate category, tier 3. Select it as your last resort. And we want, stop that clock there. We want to, what else going Oh, we have that impulse of using fluoroquinolones. It's a very good antibiotic, broad spectrum of action, and that's one of the reasons why resistance occurs so easily with that. And it's once a day, right? No, not for skin. So oral ciprofloxacin. Do you have Cipro here? Yes. And do you use it? Good, okay. Go with the veterinary products. Why? Bioavailability, not very good. This is a human product. In the United States, a lot of general practitioners were using it because it's cheaper. The generic became available, and that's what they use because fluoroquinolone is expensive, okay? Don't use it. Because it is a resistant infection, do we need to use systemic antibiotics? No, oops, no, okay? Now, after you have chosen the antibiotic, because again, it's a patient that you think needs systemic antibiotic because infection is everywhere and the coat is somewhat thick, just topicals won't be effective. Then you have to think of the dosage, frequency of administration, and duration of treatment. So, right dose. For skin, always give higher. There is a reference range there of dosing, go higher, okay? So then you hopefully can get a good concentration of the antibiotic in the skin. In mainly superficial pyoderma, we don't have vessels in the epidermis, but we need that antibiotic to get somehow there, okay? And so high dosages. Use those above the recommended range if exact dose cannot be given, okay? So then frequency, we have the time-dependent antibiotics. Those are the ones we give twice or 3 times a day. And so in this case, the consensus or what we want is that the concentration of the antibiotic at the site you're treating should be above the MIC for at least 70% of the time. Ideally, in my opinion, 100%, but they are okay if it's 70% of the time. In this case, when you're using a time-dependent antibiotic, which I hope you'll be using much more often than the dose-dependent, because again, the dose-dependent ones are all in tier 2 or tier 3, okay? And so you increase the frequency. You don't need, presuming you're already using the adequate dose, okay? So better efficacy, increase the frequency. You may even start it with 3 times a day, but that's inconvenient, right? So there's more potential for side effects. So you may not necessarily need to do that, but that's what you should do, because if you increase the dose, that won't make much of an effect, considering that you're already giving the right dose. The dose-dependent ones is, cefpodoxime, excellent antibiotic, but has a broad spectrum of action and more likely can induce resistance. Same thing, fluoroquinolones. So typically given once daily, and the important thing here is how much above the MIC that the concentration of the antibiotic on the site of infection is. Ideally should be 10 to 12 times more. So if you want to improve efficacy, in this case, increase the dosage, okay? You may already be on a very high dosage that won't apply in that case. Treat long enough, very important. But now we're starting to think, okay, are we treating this too long? Because again, that constant long exposure to antibiotic can induce resistance, okay? And then compliance can be an issue also. Owners may not, because it's a long time, weeks, right? Skin infection we treat for weeks. So may not be giving the antibiotic as you prescribe. That's a recipe for infection. So what we are trying to do, and there is a paper, a study done at the University of Illinois, I think pretty soon we'll answer some of the questions that we have. Because what is the rule of thumb that we use for many years? Superficial pyoderma, treat for 1 week after resolution of clinical signs. See, not the client seeing if it resolved. You are determining that. But that was the rule of thumb. Deep pyoderma, those are harder to treat. We would say, okay, treat for 2 weeks past resolution of clinical signs. So more studies are coming because we are hoping we'll be able to do this differently. But we are already doing that in Minnesota, okay? Superficial pyoderma, when the infection is resolved, we stop. But we spend time looking at that dog, okay? Because those lesions are small, okay? But we can see them. In deep pyodermis is a little trickier because you may see resolution at the top, but the infection is still active deep down. So you have to squeeze the skin to see, can I establish any drainage there, okay? So for deep pyoderma, we are going 1 week. And this may change. This guideline that we apply nowadays may change in the future, but we felt more comfortable. We discussed this and said, let's be brave and let's adopt this practice. Recheck is crucial. I cannot emphasize this enough, okay? Sooner than later, because then they are not exposed to antibiotics without needing. The infection may resolve in 2 weeks, depending on the case, okay? Then schedule an appointment in maybe 15 days or so. Make sure that the client will have enough antibiotic until recheck. Our technicians, if we schedule a recheck, because we try to schedule recheck appointments when the client is in the office, he's coming. And let's say the client calls, I cannot make the recheck appointment, then we give more antibiotics, schedule again, and give another antibiotic. So our clients are very compliant, so they will come for the recheck. Why? We spend time educating them, the importance of that recheck appointment, okay? But sometimes, again, they cannot come, and then make sure to give more antibiotics if you did not have given enough for this second scheduled time, okay? While the dog is antibiotics, give enough, that's what we said. Let me tell you what we are doing here. So you know, let's say you diagnose a dog with superficial pyoderma. Salt, pepper, you did your cytology, cocci bacteria, beautiful. Superficial pyoderma. And then you collect samples at that visit for culture, okay? Collect samples for culture. Send the dog home on topicals, medicated shampoo. We have those leave-on mousse, spray, rinse that contain chlorhexidine. Those are the things we typically do. If there is an area that's very focal, we may go with some topical antibiotic just in that area. Send client home. Then you call the client. You want to check in, see how things are going, but also give the result of culture and susceptibility. And then you ask the question, is the dog doing better? The client say no, you add that systemic antibiotic. If the client say yes, improve to some extent, hold there. Don't give antibiotic. Wait until recheck. If the client say it's much better, for sure, wait until recheck. And then at the recheck, you decide, does the dog need systemic antibiotics? So keep that in mind. My time is up. Just a minute. Use more topical antibiotics. So we may need to go fast. I cannot believe it. So this is the guidelines, okay, published by the World Association for Veterinary Dermatology. I won't read this, but they basically say consider topical antibiotics as first line to treat superficial bacterial infection. When again, you have to look at the extent of the lesion, also the coat, and if the owner can do it, okay? Because otherwise it's going to be failed. And so, but they're recommending there, and I'm with them. And so in this figure here, see how sad, was published in a paper from the UK, and they wanted to know how the veterinarians in the UK were, they collected a lot of data, were treating pyoderma, okay? They didn't say superficial, they said pyoderma, but most of them were, when you read the paper, were superficial pyoderma. And look at this, 64% systemic, no topical. Almost 28%, both topical and systemic, so if you combine both, it will be 90-something% systemic antibiotics to treat superficial pyoderma, only 4.7% topical antibiotics. So this is one of the things that we need to reflect and try to change, okay? So if you think systemic antibiotic is needed, go with it, okay? Select the proper antibiotic, add topical. Okay, systemic and topical. There will be cases that the owner cannot apply topical. That's okay, then systemic, okay? So every case is one case, but always try to use some form of topical therapy, okay? Because that can reduce the course of treatment with oral antibiotic, and we want that. So consider that's the first line, and then, I don't know, oh, if you, it's just to say, it can be used solely, in some cases, you'll be surprised, or in combination with systemic. And the combination systemic helps reduce the duration of treatment, okay? Why should we consider topical? Limiting topical therapy, why, right? So limiting treatment to the affected site. You don't have that collateral damage of systemic antibiotic, because systemic antibiotic kill the bad bacteria and kill the good bacteria too, the microbiome that we need. So, okay. High concentration on affected site. We talked about otitis, and again, skin, the same thing. The concentration of that antibiotic on the site is much higher than the MIC. So it should work, okay? Again, faster resolution of infection. So if you use systemic, add the topical to reduce the course, okay? And again, it may not be needed, as I told you how we do that. And now this can hopefully reduce resistance. In the protocol, see who is in the equation here? It's the dog and the owner. Every case is one case. You are going to decide the frequency, which product, systemic or topical, based on both. So if the infection is everywhere, or the dog has very thick coat that I cannot effectively use topical, go with systemic. But in the case, it may not even, but if you can do a little bit of a shampoo, maybe add that to the treatment regimen, okay? Topical antimicrobials. Oh, then, see, I probably should keep going there, because you have that in the notes. So all these products, shampoos, containing these ingredients would be effective to some extent. One thing to keep in mind, shampoos don't have residual effect, because again, and that's why we ask 5 to 10 minutes contact time to see if it's going to have a effect, okay? Then rinse, then it's gone pretty much, right? And then that's why the pharmaceutical companies are very smart. They produce, which we're thankful for them, because they produce all these formulations that they are live on. So you use those in between shampoos to have a longer effect, okay? And so, and again, chlorhexidine, all is chlorhexidine. Chlorhexidine, if you have a product that only has chlorhexidine, I would say at least 3%, okay? And so hypochlorous acid, okay? Essential oils, dermoscent, okay? They're launching dermoscent. This is a good topical for superficial pyoderma, okay? What else there? Seragine. Seragine is an antimicrobial peptide. You are not going to use that very often, but I'm fascinated with them. And then they may have some other product tailored to the patient. Yeah. So this you know. Now, let's say if you have a foci, even in between the paws, or an area on the neck that's inflamed, and you may see some papules there, or you may not. You may see more scaling, which wouldn't classify as an infection. It may be bacteria and or yeast overgrowth, which is okay. I love those. Okay, ear medications on the skin. Typically, again, Oromex, Mometomex contain clindamycin, right? Clotrimazole, and betamethasone or mometasone. So it really, because if you go with the wipe or mousse or spray containing chlorhexidine or other ingredients there, in an area that inflamed, the dog won't like it. And the owner won't like it, and they will call you. Why? A lot of these products have alcohol, which is very good even for infection, but it irritates the skin, it dries the skin, it can make things worse. So in those cases, I think I have a picture here. This interdigital dermatitis, do your cytology, see what's there, most likely malassezia and or bacteria. So I definitely go with a topical ointment again, that I mentioned, It may be until recheck, once or twice a day, okay? And I'll be doing some other things with the dog also. Same thing here. This one is a true infection. I had some papules. Let's see if I have. No, I don't have a picture of pus in that one. I told you about mipiricine, excellent antibiotic, but select that for multi-drug resistant, methicillin-resistant cases, okay? Just other non-conventional conventional topicals, alcohol gel that we use a lot during the pandemic. But again, alcohol can dry and irritate the skin, so be mindful of that. Diluted bleach for dogs that are prone to develop secondary pyoderma spores, often continue as maintenance because, again, our patients have underlying allergies. We don't cure underlying allergies. Most of them, or it's another disease that they have that we cannot cure. If we don't do the maintenance, recurrence will occur. Which allergies, even when we do maintenance, recurrences occur, but hopefully the interval of recurrences is, I put that there just to remind you. And oops, see, I knew I had a picture of it. That's using one of those ointments, was Momeromex, okay? See how beautiful. And you're treating it topically because it was a localized lesion, short-coated dog, perfect. And this dog, that was my colleague who treated this patient, so 3% shampoo, having chlorhexidine, plus chlorhexidine 3%. Ophidium is just, how can I say it? It comes from a plant and it seems to restore the skin barrier, okay? But he had this, again, multifocal to coalescing areas of alopecia, scaly at the border, so superficial pyoderma. And see how good this dog is, only topical. Okay? Identify and control underlying disease. We are almost there. Number 6, identify and control the underlying disease. Otherwise, you have recurrence. And as Dr. Marcella said, I would say consider superficial pyoderma a secondary problem until proven otherwise. Look for that underlying disease. Failure to identify an underlying skin disease and properly manage it is the most common reason for persistent or recurrent pyoderma, okay? Client education. So, and then we'll be done. Crucial for a successful, it's actually, you know that. Just spend the time. This is precious. You need to properly educate the client, okay? Otherwise, the client don't think you're good, gets upset after you, and doesn't do what you recommended to do, okay? Spend the time. Clients I even call them. I call them to see how they are doing, how the pet is doing, and they feel like you care, okay? So even if things don't go as well, they trust you because you care for the patient. And they will be more compliant. So it's very important that you find that spot there. I bet you have quite a few clients like that. Takeaways: use more topical antibiotics. Select first tier first. If second or third tier, culture. Address underlying disease, recheck, and educate the client. Done. So I think Jairan will kill me if I ask if there are any questions, but you can talk to me if you have any questions, right? Or it's okay? No? Okay. Ish, I have to go.
Thank you, Dr. Sheila, for the wonderful lecture, and we are really sorry for pushing you through the lecture, but after the lunch promise, I hope that we will not push you through the whole session. Thank you so much.